Welcome, everyone. It's great to have so many of us here tonight. My name is Dr. Ben Buchanan, and I'm really pleased to be hosting tonight's webinar. I'm a clinical psychologist and the CEO of NovoPsych, and I'm absolutely thrilled to be joined by Dr. Sharelle Smith tonight, who is going to give us a great taste of some of her work she's done in her PhD and beyond on trauma recovery. At NovoPsych, we love running these sessions because they give us a chance to connect with an incredible community of mental health professionals who use our tools, psychologists, psychiatrists, GPs, and OTs, mental health clinicians of all kinds around the world who want to invest their time in delivering high quality care. And so it's really great for everyone to be here right now, investing in their skills so that they can better serve their clients. And I believe that robust assessment and measuring outcomes is a cornerstone of evaluating our treatment and getting better as clinicians. And NovoPsych provides a wide range of psychological measures and questionnaires, and we'll learn about some of them tonight. But tonight's really about diving deeper into the theoretical framework around trauma recovery. So without further ado, I'd like to introduce Dr. Sharelle Smith, who's a clinical psychologist and principal psychologist at the Leitner Center. Sharelle completed her PhD, a Master's of Clinical Psychology, postgrad diploma of psychology at Bond University, as well as a Bachelor of Science at Monash University. That's where I went. What a great university that is. Sharelle has a special interest in the treatment of complex trauma and facilitation of trauma recovery, and has completed additional training in trauma-focused interventions, including trauma-informed stabilization treatment, sensory motor psychotherapy, and trauma-focused cognitive behavior therapy. We are extremely lucky to have Sharelle here tonight to talk us through some of the work that she's done in her PhD and beyond. So Sharelle, welcome, and thank you for doing this webinar and being with us here tonight.
Thanks for having me, Ben, and thank you for everyone who's joined on board. I can see that there's been lots of people from lots of different countries, so it's super exciting that there's other people excited about trauma recovery.
Yeah, absolutely. And so you developed what we're going to be talking about, part of it, at least what we're talking about, is the trauma recovery measure. So you developed this as part of your PhD. How did you end up focusing on this area?
So it's actually a happy accident in one way. I did start out looking at trauma recovery, and my initial goal of my PhD was to provide a face-to-face intervention for trauma recovery and then measure telomeres, which are the little kind of ends of DNA to kind of track recovery progress and see if we could monitor it in that way. But after doing some training over in the US and flying back, it happened to align with the COVID border closures, which then scrolled into no face-to-face contact for client care. So my initial goal of providing that intervention was kind of out the window. And so then kind of looked at how then I could kind of, I guess, streamline my interest in trauma recovery and what that looked like in the clinical setting without being able to do clinical service delivery. And so then that kind of led me down the path of kind of, well, what is trauma recovery? How do we define it? How do we measure it so that we can accurately treat it and, help people in that space?
And I suppose what you'll be talking about tonight is the really reframing trauma recovery. And that's what I really appreciate about your work. Because, for me in my training and certainly the way, many clinicians are trained is, that recovery is a reduction of symptoms, but you've totally reframed that. Really love the way you've done it. So over to you, Sharelle.
Perfect. Thanks, Ben. My goal is really to talk around recovery from trauma and really what that looks like. I'm not going to be focusing on interventions. The model I've developed, the trauma recovery measure, works for, it doesn't matter what service delivery method you use, we're really looking at how we can define it, how we can assess it, and what that looks like as far as treatment outcomes. So the objectives for me is by the end of this webinar that you should be able to understand the current or historical challenges in defining and assessing trauma recovery, explain how the trauma recovery measure conceptualizes recovery, interpret the trauma recovery measure scores and link them to the different recovery stages, and learn how to apply the trauma recovery insights and guide treatment planning and monitor progress. So what is trauma recovery? So at present, or at least at the time I was doing my PhD in research, there was no general consensus on the definition of trauma recovery in the professional literature. So from a clinical perspective, all definitions of recovery had been drawn from the medical literature and conceptualizations related to physical illness and disability. So these frameworks adopted an illness ideology that focused on weakness and deficits as opposed to strengths and well-being. It emphasized abnormality over normality and maladjustment over adaptive change. These illness ideologies prescribed the complete absence of symptomology and/or a return to premorbid functioning as indicators of recovery. With my mouse here. So in contrast to the deficit model, which identified a chronic and often permanent experience of psychopathology, symptomology, and vulnerability, psychological frameworks have adopted a strengths-based perspective that promotes recovery within illness as opposed to recovery from illness. So within this conceptualization, we see recovery being theorized to occur concurrently with symptom abatement. However, this relationship is not always linear, and there's not necessarily needs to be an absence of psychopathology or symptomology to achieve recovery. There is a general consensus within the psychological literature that recovery from trauma does not imply a return to premorbid levels of functioning or the eradication of trauma-related symptoms, but rather proposes a process of intrapersonal development and understanding that promotes hope and personal well-being through adaptive changes within the identified domains of recovery. So the attainment of recovery following trauma exposure does not change or minimize the occurrence of the traumatic events. The experience of memories, cognitive, emotional, and behavioral symptoms, and so the psychosocial impacts are often still present, and the individual's life has obviously been irreversibly changed by their exposure to trauma. However, the process of recovery indicates that the individual is transforming, that they're developing control or mastery of themselves, and that they feel empowered to engage in their life and in the future. So recovery within this definition is not identified to be synonymous with the concept of post-traumatic growth that a lot of people might be familiar with. So post-traumatic growth itself refers to positive psychological change that's experienced as a result of the struggle with highly challenging life circumstances. So post-traumatic growth is not identified to be a direct result from trauma exposure, but rather how the survivor struggles as a result of their trauma exposure. So within this conceptualization, the attainment of post-traumatic growth is theorized to progress beyond an individual's pre-trauma level of functioning and to succeed or expand upon recovery. Post-traumatic growth is proposed to exist on a separate continuum to recovery, and the attainment of recovery is proposed to support post-traumatic growth. Okay. So in reviewing the literature on trauma recovery, I drew upon the strengths-based conceptualization that views recovery as a non-linear process of interpersonal development, transformation, and empowerment, rather than a return to premorbid functioning or an absence of psychopathology. So from this foundation, I developed what I call the cognitive model of trauma recovery, which translates these principles into a framework centered on positive cognitive change. So specifically, the cognitive model of trauma recovery proposes that recovery is achieved through a gradual development of cognitions that support safety, security, and self-identity, moving individuals along a continuum from self-condemnation, blame, and self-loathing towards acceptance, empowerment, and self-compassion. So this cognitive shift allows individuals to move away from a predominance of negative, deficit-driven cognitive processes that have been demonstrated to precipitate and maintain maladaptive and negative behavioral and emotional reactions towards a mastery of safe, secure, and strengths-based cognitive processes. And these reinforce the individual's sense of autonomy, safety, and self-control. So this figure illustrates the cognitive model of trauma recovery. So at the center, we have trauma recovery, which is understood as a process of rebuilding the self and strengthening positive cognitive patterns. Recovery in this model is supported by three key domains. So the first domain, the positive self at the top of the triangle there, this is where survivors come to see themselves as capable and resilient. They have beliefs, hopefully when they're sitting in the recovery space, of I can rely on myself and I have overcome my traumatic experiences. So these thought processes and beliefs you'll actually see reflected in the trauma recovery measure as we move towards it at the end. The validation domain reflects self-worth and self-acceptance. So with cognitions such as I am enough or I respect myself. And then within the liberation domain, which focuses on empowerment and freedom, we will often see clients hopefully developing self-statements such as I'm in control of my life or I feel free to make my own decision. So together these domains show that recovery is not only about reducing distress, but it's also about fostering strength, self-respect, and empowerment. So then this kind of moves on to the definition of trauma recovery. So the cognitive shifts that are proposed within the cognitive model of trauma recovery support a move away from a predominance of negative, deficit-driven post-trauma cognitions towards a mastery of the safe, secure, strengths-based cognitions that reinforce this sense of autonomy, safety, and self-control. So within this framework, I've defined trauma recovery as an individual process of cognitive, emotional, and behavioral adaptation and change that results in the attainment of interpersonal mastery, empowerment, and hope for oneself and the future. So alongside the development of a definition and model for trauma recovery, there was a very clear need to create a way to assess trauma recovery in both clinical practice and research. Currently, the way that we monitor treatment outcomes in trauma work is often through measures that identify and evaluate negative or maladaptive cognitions and symptoms. So in the trauma space, common tools that we use, things like the PCL5, the DAS-25, or the ITQ, just a few, focused almost entirely on what is going wrong, on the symptoms of distress and psychopathology, which reflects past understanding of trauma recovery and including the medical and deficit model. So what we're doing when we're using these measures is we're looking at purely symptom function and symptom abatement in the clinical treatment space. So this model of assessment and monitoring emphasizes symptom reduction rather than positive changes and growth. And when we look at clinical treatment, our goal really is for therapeutic intervention to support growth and development alongside symptom reduction. The problem with relying only on these previous tools, so the DAS, for example, the PCL5, the ITQ, is that they can unintentionally reinforce negative trauma-related beliefs. They can limit a person's capacity to recognize their progress and strengths, and sometimes even trigger or intensify trauma-related symptoms during assessment. So I think too, I guess in the research space, quite often we have difficulties getting ethical approval when we're looking at especially measuring and kind of assessing the trauma-related populations when we're purely looking at these kind of maladaptive symptom tools, because we need to be aware of the distress that may be caused when they're actually completing these measures. Similarly, kind of in the clinical space, if we're sitting there working with a client and we're trying to focus on positive outcomes, positive treatment goals, yet we're using deficit-driven assessment measures, it kind of counteracts what we're doing in the treatment setting. So at present, there's no available outcome measure that specifically captures trauma recovery. So this highlights a major gap in our clinical research practice and underscores the need for a measure that aligns more closely with the recovery process. Okay. So due to the absence of alternative ways to assess trauma recovery, this is why the trauma recovery measure was developed. So its foundation draws upon previous research, as well as the established relationship between post-trauma cognitions, trauma-related psychopathology, and the newly developed cognitive model of trauma recovery. So research has consistently shown that reducing the post-trauma cognitions, things like shame, blame, and negative self-perception, often leads to a reduction in PTSD symptoms and supports the process of trauma recovery. However, the cognitive model of trauma recovery that we've discussed previously inverts this hypothesis and proposes an enhancement of positive cognitions that minimizes the role and impact of these negative cognitions and supports recovery. So ultimately, the goal was to use this theory to create a positive, strengths-based instrument that could capture recovery following trauma. To achieve this, the trauma recovery was designed to be a brief, simple to understand and administer a measure that was relevant across different trauma populations, was sensitive to change over time, and was psychometrically robust. So whilst the TRM was initially developed for survivors of interpersonal violence and was initially, I guess, psychometrically validated on this population, it's also now been validated on general population sample, as well as a clinical population sample of individuals with exposure to non-personal forms of trauma exposure. So things like motor vehicle accidents, natural disasters, as well as multiple different types of trauma exposure and interpersonal trauma exposure. So the TRM itself has demonstrated excellent reliability and validity and demonstrated large negative correlations with scores on the PCL5, the DAS, and the K10. So what this means is with the TRM, the higher the scores on the TRM, the lower the scores we're getting on psychological distress scales and negative symptom scales like the PCL5, the DAS, and the K10. The TRM also has a small positive correlation demonstrated with the self-compassion scale, indicating that there's two measures align quite closely. The TRM has been demonstrated to differentiate between exposure to non-personal and interpersonal forms of trauma exposure. So what we see with these populations is that individuals who experience interpersonal forms of trauma typically score higher on measures of like PCL5 and the DAS-21, and they also score lower on the trauma recovery measure. There's also been demonstrated to be a significant difference between the severity or the violent, I guess, the level of violence associated with different types of trauma exposure. So things like physical assault, sexual assault, severe human suffering, those type of interpersonal trauma typologies compared to other types of interpersonal trauma, with individuals who experience these more violent types of trauma scoring higher on PCL5, higher on DAS, so higher symptoms of trauma, higher symptoms of psychological distress, and lower scores on the trauma recovery measure. Adding on to this, I guess the TRM has also shown an ability to differentiate between individuals who report clinically significant symptoms of PTSD and individuals who don't report clinically significant symptoms of PTSD. So again, when we look at, I guess, the correlations between those, individuals who have clinically significant PTSD also score lower on the PCL5, also score lower on the TRM, sorry. And individuals who score lower on the PCL5 or have lower levels of trauma symptoms obviously are scoring higher on recovery measure. And I guess finally, the TRM has been demonstrated to be a significant predictor and to account for a significant 54.4% of the variability in scores on the PCL5. So every item on the measure, as well as the subscales and the total scale, have all been demonstrated to be individual predictors of PTSD. What this means is that we can use the TRM in clinical settings, and looking at the stages of recovery identified within the TRM, we can determine where a client is sitting in relation to their levels of PTSD symptoms without having to apply the PTSD scales at every time point.
So Sharelle, can I just jump in? There's a few questions that have come up that'd be interesting to put to you. You mentioned that administering some of the standard measures like the PCL5 can be a negative experience for clients. I've seen the same thing. I suppose what impact do you think that has on the therapeutic process? Because I suppose it means that the measurement, the process of measurement becomes part of the therapeutic process, right? But if we're administering ones that aren't a positive experience, what's your sense of, with your clients, how you've seen it, that shift impact them?
Yeah, and I guess one of the things that we might have here in Australia or with some of our clientele that not everyone shares is obviously, things like reporting processes for funding and things like that. I'm thinking particularly if anyone in Australia thinks around Medicare reporting and looking at outcome measures and, what that looks like. So typically for, whether it's for referrals or insurance purposes, quite often we have to report on progress in treatment. And, historically, that's always been around, typically things like the DAS-21, the KTN, maybe the PCL5, or a whole range of different outcome measures that people use. when we're looking at that, I mean, those things great in one way when you're able to show progress through treatment and, a reduction in symptom output. But we're still having to ask them those same questions, like, are you experiencing this? Are you experiencing that? And whether you're doing it at the start of a session or the end of the session, that's kind of where you're setting the foundation for what you're talking about with your clients.
So it's almost like setting the agenda, and what we're measuring is the thing that the clinician and the client can't help but focus on.
Yeah, absolutely. And I think it's also, especially for people sitting in the kind of, and in most modalities, I guess, one of the goals in treatment is to really shift the focus or change those negative cognitive processes. Yet what we do is we're measuring those negative cognitive processes. And so the trauma recovery measure actually gives you an option to focus on the positive, focus on those strengths-based outcomes, and be able to track progress towards goals, which are about feeling safe, feeling secure, feeling in control of your life. And that's, sets a really great foundation when you're talking to the clients around, okay, this is where we're at. This is the progress that you're making towards your recovery goals. And I think that really fosters that sense of empowerment for people.
Yeah, absolutely. There's heaps more questions, but I'm going to let you continue.
Okay, thanks. Okay. Okay. So this is, I guess, a bit of a view of the trauma recovery measure itself. And so when we're looking at the trauma recovery measure, what we're doing is we're asking individuals to consider how they've felt about themselves over the last week and indicate the degree to which they believe the statements provided are true of them. So much like everything we do with the measure, it's all positively scored. So we start from 5 being the highest to 1 the lowest. So we want to know, is this true of you or is this untrue of you? So still quite in that positive space. So it's not like an absence of this or an absence that's like, is it how true? How does this resonate for you? And so when we look down, I guess the questions, we're asking about these positive self statements. So I respect myself. I'm free to make my own decisions. I'm in control of my life and my decisions. I accept all parts of myself. I know my worth as a person. I'm empowered to pursue my goals. I've overcome my traumatic experiences. I like myself. I have hope for my future. I'm worthy of love. I can rely on myself. I choose to focus on myself and my future. I am enough. I have changed for the better, and I can cope with life's ups and downs. So you can see, I guess, how, administering this either pre-session or at the end of a session really kind of sets a really positive foundation for where we're talking, what we're looking at, how the individual feels about themselves. So when we look at scoring of the TRM, so scores provide an evaluation of the individual's current recovery journey, with lower scores indicating the individual to be in the early stage of recovery and high scores indicating engagement in the late stage of recovery. So the total score on the TRM ranges from 15 to 75, with higher scores indicating the individual to be in the later stage of recovery and lower scores the early stage. So the TRM has 3 subscales: validation, liberation, and positive self. And if you can recall from the cognitive model of trauma recovery, this is an exact replica of that model. So the validation subscale measures individuals' approval and acceptance of themselves as they are, despite their experience of trauma, and assesses the development of internal value and worthiness. The liberation subscale measures an individual's ability to release or set themselves free from the control, imprisonment, and/or oppression of their trauma, and to live a life in which they feel capable and confident to make positive decisions for themselves and others. The positive self subscale measures the presence of positive cognitions that generate feelings of care, compassion, or comfort towards oneself. So average scores for subscales are presented to allow for a comparison across the 3 subscales, given that each 3 subscales have different item numbers within each scale. So percentile scores are also presented for the total score and subscales in comparison to both a clinical and a general population sample. So the clinical population sample that we use in the data here is representative of individuals who've been exposed to traumatic experiences and who are currently experiencing clinically significant symptoms of PTSD. So when we're looking at interpretation of the scores, so results are presented for the total and subscale scores with a graph and a descriptive output. So this on the right, you can see a bit of a sample of what the figure output would look like. So on the first administration, a plot is presented that shows the total and subscale clinical percentiles. The recovery stage is displayed in the background of the plot to aid in interpretation. So this graph can assist in conceptualizing scores in comparison to the distribution of responses among both clinical and non-clinical populations, as you can see in the figure on the bottom right-hand side there. So at the end of the report, a comparison plot provides information about where the respondent sits in relation to the normative and clinical population samples, and the shaded areas around the means indicate the two middle quartiles, as you can see in the bottom right. So with this, you get basically a really great descriptive output as well. So a summary, output for the images that you can see on the screen now will be something like the following. So the client's total score on the trauma recovery measure, as assessed on the date, was 39 and the 31st clinical percentile, which indicates they're in the middle stage of trauma recovery. This suggests the client is making progress in their journey and is developing more adaptive cognitions related to their trauma. And then you also get a breakdown for both the validation, liberation, and positive self scores. So if I give you a bit of an overview of what, let's say, the liberation one would look like. So the client's liberation subscale score is 9, average score of 3, which is at the 41st clinical percentile, indicating they're at the middle stage of recovery. This suggests the client is developing a personal sense of autonomy and control and is able to experience thoughts and feelings related to confidence, capability, and self-determination. So if we look at the client's positive self-score, you can see it's in the early stage in contrast to the others that are sitting in the middle. So you get feedback or input that looks like the following. So the client's positive self-subscale score is 9, average score of 1.5, which is at the 5th clinical percentile, indicating they're in the early stage of recovery. This suggests the client is working towards a strong positive self-identity and is developing an awareness of thoughts and feelings related to the care and compassion. When we have the end of the output, it also provides treatment recommendations, which I think is a really, really nice, summary and kind of really works with the strengths-based model that we're working with. So recommendations at the end of the interpretation would look something like this for this specific client. So treatment may focus on reinforcing the client's developing adaptive self-cognitions with a particular focus on areas where they remain in the early stage of recovery or show less improvement, for example, positive self. Supportive therapeutic approaches that strengthen feelings of self-worth, control, and self-care are likely to be beneficial. The great thing about the measure is that when administered on a regular basis, what we get from Novopsych is longitudinal plots for both the total score and the subscale percentiles. And this indicates or provides information about the changing cognitions over time and can be used as a positive outcome measure for trauma recovery. So the image you can see on your screen is the comparison plot for each of the individual subscales, so validation, liberation, and positive self. So you can see obviously time point 1, time point 2, and time point 3, and a nice progress through treatment in that space. So this also comes with, the comparison score output, as you can see there. And I guess a summary for this client would really be the client's current total score on the trauma recovery measure is 69, which has increased from 48 and indicates progression from the middle to the late stage of trauma recovery. This suggests the client has made significant progress in their recovery journey and frequently experiences adaptive cognitions related to their trauma experience. And then you
Sharelle, some good questions coming in. Michelle asks, how frequently do you personally administer the TRM to your clients?
At the moment, it's 6 weekly. So we do it prior to the initial appointment, and then we're doing it at 6 session, 12 session, and ongoing from there.
Yeah, cool.
When we jump back into this example just here, so we can see that the client's showing progress in their trauma recovery, with the most notable improvement being within the validation domain. They've moved through from the early to the middle. And so treatment may continue to build on these gains while addressing domains with less pronounced improvement. But I guess for this individual, what we can see has been a really nice progression for all of the domains. And obviously that the treatment, this indicates, the treatment's working towards, really enhancing those positive sense of self-empowerment, autonomy for this individual, which is lovely to see. So when we look at the interpretation of what the recovery stages mean, and I think this is an important space. So the stage of recovery descriptor is also presented based on the scored distance from the mean. So there's 3 possible stages of recovery within the trauma recovery measure. So the early stage of recovery, so we're looking at scores less than 1 standard deviation below the mean. So this stage suggests that the individual is in what we would call the beginning phase of their recovery journey. They're working towards developing adaptive cognitions related to their trauma experience with an emerging awareness of self-worth, personal autonomy, and self-compassion. When we look at the middle stage of recovery, so this is between 1 standard deviation and 2 standard deviations below and above the mean. So this stage suggests the individual is making progress in their recovery journey. They're developing more adaptive cognitions related to their trauma experience and are able to experience moments of self-acceptance, personal control, and positive self-regard. In the late stage of recovery, so scores greater than 1 standard deviation around the mean, this stage suggests the individual has made significant progress in their trauma recovery journey. They frequently experience adaptive cognitions related to their trauma and demonstrate consistent self-acceptance, personal autonomy, and self-compassion. So then we're looking, I guess, at the clinical applications of the TRM. So clinically, the TRM helps us track recovery trajectories over time. It guides strength-based interventions and supports recovery-oriented practice. It also makes progress visible for clients. It enhances collaboration in therapy and gives us a more meaningful way to evaluate treatment effectiveness. Ultimately, the TRM bridges the gap between symptom reduction and true recovery, offering us a tool that better aligns with what both clinicians and survivors want most. So really specifically, I guess, to break this down, what the TRM helps to do. So it helps track an individual's recovery trajectory across the continuum from self-condemnation and blame towards acceptance, empowerment, and self-compassion. It helps identify and strengthen positive cognitions that support safety, security, and self-identity. It guides clinicians to deliver strength-building, recovery-oriented interventions rather than symptom-focused treatment only. It monitors change over time, capturing both symptom reduction and gains in well-being, resilience, and empowerment. It provides a structured framework for recovery-oriented practice, aligning therapeutic goals with the individual's lived experience of recovery. And it enhances a shared understanding and collaboration between the client and clinician, making the recovery progress really visible and tangible. It evaluates treatment effectiveness through positive outcome measurement and complements traditional symptom-focused tools. It supports service level planning and research by offering a standardized measure of trauma recovery, bridging the gap between practice, research, and policy. So I guess in a summary of kind of the trauma recovery measure and where it's sitting. So clinically, it helps us track recovery trajectories over time, and it guides us strength-based interventions to support recovery-oriented practice. It obviously makes progress really visible, and I think this is one of the strengths of using Novopsych in this platform is the graphs. It's the provision of that visual information that really, really supports, I guess, clients to be able to see where they're at. And ultimately bridges the gap between what we're doing now with symptom management, symptom monitoring, and true recovery, offering us a tool that really aligns with what we're looking for and what both clinicians and survivors value most, which is transformation, empowerment, and well-being.
Excellent. So there's lots of questions coming up, but before I get into all of the questions, and there's lots I want to put to you, I just want to share my screen and just um, show the audience some of what is possible on Novopsych. So as you can see on my screen, the trauma recovery measure is here. I think that some people, well, I certainly invited people to press administer now at the start to measure themselves. One of the glorious things I love about this measure is it's not, it's so broad actually. I'm not sure you even need to have experienced trauma for it to be applicable to you. And and so here we can see the PDF. There was a question that came up saying, can I administer it paper and pencil? Yes, you can. You can download the PDF there, but you will have to hand score it. Um, and then we've got some sample reports here. And some other trauma measures that I just wanted to draw people's attention to is some classic ones, I suppose, with for example, the International Trauma Questionnaire, which is a great measure at measuring the core symptoms of PTSD, that re-experiencing, that avoidance, and the sense of threat. And I suppose, the contrast between the TRM and these other measures are really plain, aren't they? Like the symptom-based versus the positive reframe that Sharelle, you've done so well at. The other thing that I really like about the International Trauma Questionnaire, though, is that its capacity to distinguish between PTSD and complex PTSD, with the disturbances of self-organization being one of the core things that's relevant to complex trauma. And if we click into this, we can see all of the different subscales that are measured on the PTSD subscales, but then also on the disturbance of self-organization subscales, including affective dysregulation, negative self-concept, disturbance in relationships, and functional disbandment. I can't help but think that negative self-concept is almost the flip side or the reverse of some of the concepts measured in the TRM, which is interesting. And then another classic is the PCL5. Obviously, some of the reporting and a high quality assessment still requires sort of a DSM focused or a clinical sort of framework to do the assessment and diagnosis. And so the PCL5 is really good at that. And when administered through NovoPsych, the PCL5 will be evaluated against the DSM-5 criteria. And you can see in this sample result, for example, this black dots here in the red zone are representing that they are above the threshold for a PTSD diagnosis. And so all of these things can go along with the TRM, perhaps, the PCL5 or the International Trauma Questionnaire as the initial assessments, and then the trauma recovery measure really being that outcome monitoring part of it. And of course, all of these, if you go to NovoPsych and then click into assessments, and then press trauma, you'll see a huge library of trauma measures. And so I'd really encourage you to have a look at them, as well as look at the TRM. Within NovoPsych, if you log in, you can see here I've got the trauma recovery measure that I've administered 3 times. And I really do love that graph and how you can really see the trajectory of treatment over time. And I think, from what I see as well, clients really love it because what these graphs allow us to do is turn the invisible and intangible into something real, tangible, something that's you can see. And as they say, seeing is believing. And there's a reason why such a huge proportion of our brain is devoted to our visual cortex, because visuals are so powerful. And so I think with the TRM, it really does a great job at that. So Sharelle, thank you for sharing that with us. I've got a bunch of questions for you. Coming back to that question I asked at the start about I suppose what I've always found is that the assessment process is therapeutic in itself. Like, I think that sometimes if we're just doing assessment, just for a diagnostic reason or just for reporting reasons, that it doesn't end up being therapeutic. But I've also seen assessment cause harm. For example, on the adverse childhood experiences scale, which is also on NovoPsych, asking about traumatic childhood experiences and it causing harm. So I suppose for you, when you're doing therapy, is the conversation, does the TRM like scaffold conversations, or how does it work, and how does it contribute to the actual therapeutic process?
Yeah, and I think that's a really good point. I think I use, outcome measures and diagnostic tools, I guess, to inform treatment planning and really guide, I guess, goal setting with clients early. So when we do have to do, specific measures for, insurance or other purposes, what we do, we actually scaffold the questionnaire. So we start obviously with, the DAS, the PCL5. We always end off with the trauma recovery measure. It's always the last one that's delivered. So we're ending off on that really positive frame. And so that's the same process we go through when we're actually going through I guess the scoring and interpretation. So we start off with those, but we always end towards what we're working towards.
Yeah. I suppose it's interesting what we're working towards being the key thing. It's like, um, uh, yeah, and there were some comments in the chat about it being a classic sort of positive psychology reframe. That what we're going towards is the thing that matters. Um, how do you score on the trauma recovery measure? Because I self-administered it. And I thought the questions were great. I'm thinking about routinely administering it to myself just to see how my life is going. How, is it applicable, or have you thought about how wide it can be applied, or is it really trauma specific?
I haven't yet, but I'm always keen in doing further research. So, part of what I'm doing is always growing and developing the measure. I saw a question pop up just really briefly around an under 18s, and I would love to have an under 18 version of this validated, because I think it's such a nice space to be able to see it, especially for that, younger population, whereby we can start using these positively framed, measurement tools instead of just, really focusing on symptoms. And I think if we can implement that early, I think we can get some great, change happening in that space as well. So there's definitely a lot more I want to do with the measure. And that also looks like how it expands into different spaces.
Yeah. And so Laurie asks about how the trauma recovery measure and trauma, I suppose, in general, or your conceptualization of it is how closely related to attachment were you thinking when you were developing the measure? And is it conceptualized around inter or intra personal sort of dynamics? What's your sense of that?
And so it's mostly intrapersonal. So obviously, once we have that intrapersonal sense of development, safety, and stability, that then fosters interpersonal development and safety, because I don't believe we can have the latter without the first. And so it really sits in that early space of interpersonal safety, security, and decision making and control, so that then you can feel comfortable, especially when we're looking at things like complex trauma. You need to have that really stable base before you can feel safe enough to then develop safe, stable relationships with other people.
Yeah. And you were mentioning before we got on that you're doing a bit of work with defense and administering it to members of the Defense Force. How are they finding it? What's the client reception to you administering this measure?
It's been really positively received, and I think for anyone who's using it, it's been really positive received, because I guess it's a shift from what they've been doing previously. And so, I've seen a lot of patients. I see a lot of patients who've been in treatment for 20 plus years, and so being able to introduce this is completely different to what they're used to. But it also really, I guess, it's a really lovely approach for them, because they can see that it sits really nicely with what they're hoping to achieve in treatment.
Yeah, right. It's I mean, to have someone that's been in treatment for all that time and it's all symptoms based and then just that reframe, I think, could be so powerful. I was interested that you're only administering it once every 6 weeks. When I administer outcome monitoring scales, I typically do it every second session, because it gets into a routine, and I would do it. I would do it actually part of the therapy session. I know lots of people do it at reception or whatever, but I like part of it so it becomes part of the conversation. And I suppose, especially with the TRM, it's a pretty short measure, so it might take 1, 2 minutes or something. Um, what what sort of patterns have you seen with your clients? I mean, it's not just everyone recovering, right? It's people going backwards as well. Like,
Yeah.
what are you seeing there?
And I guess it's why, I guess 6 weeks gives you a more, like, I guess, a wider scope, because I guess a lot of the work I do is with complex trauma. And
Yeah.
so, that's not a linear recovery. Like any recovery journey, it's not linear. And so, you're going to have your setbacks, you're going to have, additional stresses of life that are going to, throw out of whack your treatment plan and, where you're at as far as, your recovery and your ability to implement things. And so with anything, whether it's distress, whether it's trauma symptoms, things do fluctuate. And so it's more about what we're looking about is, longitudinally over the course of treatment, are we heading in the direction that we want to head?
Yeah. And Jess asks, do
Mhm.
you see the domains increase in any particular order? Like, do you find that, yeah, like any patterns there?
And I think it really depends on the individual. So I think when we're looking at, really severe, I guess, interpersonal forms of trauma, one of the things I see a lot is that loss of control. And sometimes that's, a really difficult space to actually build in the early stages. And that quite often you see, say, for example, you're working with someone who's come out of a domestic violence relationship and they've still got contact with the perpetrator because of shared childcare responsibilities or things like that. So quite often, trying to develop someone's sense of autonomy and control in that space can be really difficult because there isn't quite often a lot of control and autonomy in that space when you're wading through court processes and those things. So there's a lot of other factors that are involved. So quite often that can be a slower one to develop. But it really depends on individuals' histories. So if we're looking at things more like, complex childhood trauma, it may be more the positive sense of self that may be harder to develop if they've got really, complex, internal sense of, self that's been negative from, really early childhood stages or ongoing attachment difficulties in that space. So it's very much a personalized.
Yeah. And Talia says, although the PCL5, the DAS21, and the RTQ is something sometimes reflects deficits, is it still something that helps us understand the extent to which there may have been traumatic instances? We're not abandoning these measures altogether, right?
No, we're not abandoning them altogether, but I think it's more about like, do we have an option not to use them every time? And I think if we're looking at how frequent we're doing it, or even if we're looking more towards the research space or, more community settings where we're not providing therapy, but we're looking at current, diagnostics, current, symptom clusters and things like that, do we have an option not to have to administer these things? And I think having an option and having a choice in this space is really, I guess, a benefit that we can offer.
Yeah. Do you uh, do you think that in the trauma space we are going to see people sort of do the positive reframe thing, or do you think that we're going to be stuck with the sort of symptom-based stuff for a while? I mean, and I'm in an interesting position, right? Because Novosite, we have most of our measures are deficit focused, honestly, and many of them are DSM centric, and I think that that's really, really helpful. But then one of the reasons why, I think it's great we're doing this webinar is to show people that there are these alternatives. But I personally think that the way treatment's going to work is that we still will think in terms of, DSM centric sort of disorder focused ways of thinking. Do you see things shifting, or do you think you're just going to contribute your little bit and that's enough? Or how do you think it's going to play out?
Well, I guess a couple of things. I guess my first thing is, one of the things I want to offer in this space is some choice for individuals around what they have to, on how we assess. And quite often, we don't give people a choice in that space. So if people find the PCL5 distressing or the DAS distressing, we do have another option that we can provide. I guess the second space is because the TRM has such a strong relationship to PTSD and the predictive capacity, we can administer the TRM as an initial measure, and then individuals who are scoring in the early stage of recovery, or maybe even the middle stage of recovery, then we can provide the PCL5 and the other diagnostic measures. If they're scoring in the late stage of recovery, due to the significant predictive ability in the relationship between PTSD and TRM, we can literally then decide, do we actually need to administer this measure? Because this person is saying that they're at the late stage of recovery, and we know that typically that means that they're not going to be showing clinically significant signs of PTSD.
I suppose on that, someone asked a question. How does the TRM distinguish between what trauma is and what run-of-the-mill depression is? And this person was wondering, can it with specificity discriminate? I suppose I think, well, I don't know. You're the expert. What do you think?
Well, when we looked at the scales and the psychometrics actually show, so when we looked at psychological distress using the K10, there's also that significant predictive relationship between psychological distress, which is predominantly depression, anxiety on the K10, and the TRM, the same relationship that we see with PTSD. And so people scoring the late stage of recovery are likely to have a lot less symptoms of psychological distress and not likely to meet the criteria for depression and anxiety.
All right. Interesting. And uh, so Cass asks, do you find that if a client is disengaging from therapy or going backwards in the assessment, um, that they might that this might be reflected, or that the TRM can sort of predict whether how engaged they are in therapy?
I guess that's an interesting space. It's not something we've looked at specifically at the moment. And I think, obviously we need to use our clinical impression and obviously our clinical understanding of the client in that space. But I think any client who's engaging in, measures and giving you information, I said they're giving you they're giving you something to kind of work with, and that can always inform kind of where they're at. So if someone's really struggling with their, positive sense of self, maybe that's an area that's kind of making them reluctant to engage or maybe pulling them back further. But it'll always give us some sort of information around kind of where they're at the moment, and maybe help us give, a little bit of an in to be able to work with them in that space.
Yeah. Have you ever seen anyone pretend that they've got it all together on the TRM and like everything's fine, everything's really great, and you sort of think, oh, I don't think they're fully telling us what's going on.
I haven't yet, no, but I
Uh,
guess I'm hopeful it's in the same space of, a client comes in and says, yeah, my week's been great, but then in the next, 5 minutes, everything kind of unfolds. So I think, outcome measures kind of take away that need for positive approval or impression management that quite often, you get with clients, especially if they're, providing their feedback and their responses outside the clinical room. I think it provides a bit of safe space for them to be able to be open and honest, and then give you some, I guess, insight and ability to kind of then address those things in treatment.
Yeah. So someone's asking here, lots of questions actually, it's hard to keep up, but someone's saying, or someone's doing a suggestion, that it would be appropriate to give back to a GP as a way of, what I love doing with my GP letters is screenshotting the graph from NovoPsych and then just showing the GP, the start, middle, and end, maybe 3 time points on a measure. And I think, with our busy GP colleagues, a picture tells 1,000 words, and I think a graph tells at least 100. And so yeah, it's a good thing to be thinking about. Um, Someone's asking, has the measure been used with people with other mental illnesses? Oh, we did talk about that before. Um, wanting to, I suppose, wanting to validate it. I mean, I don't have a mental illness at all at the moment, and I loved it for me. So it seems like it could be a very widely applicable measure.
Yeah, absolutely. And I think probably most of us know, people presenting in trauma don't necessarily just have trauma. And most people presenting, have a lot of other symptoms, a lot of things going on for them. And so obviously, when we're providing the measure, it's not just people who are, booking in to see me regarding trauma or what that looks like, but it's also kind of a measure that we're providing to see where people are at.
Yeah. And in your experience, what do you think predicts people's capacity to recover from trauma the best? Like what's your sense about, when someone walks into your office and you think, oh, this person's stuck versus this person might bounce back. What's your sense of that?
And I'd like to think that I don't think, anyone's completely stuck. And my hope for everyone is that there is an option for recovery. And I think the fact that someone's sitting in front of me saying, I want to recover, or I want help, or I want support, or, I'm not happy with where I'm at, is indicative of their, capacity to recover.
Yeah, that's a really you're a positive psychologist, I can tell. Yeah, and I suppose we hold hope for our clients, and need to hold hope, and that's part of the job, right? Of seeing the strengths and seeing everyone's capacity to recover and do better. There's another question here. Elena asks, is there any talk about possibly switching to the use of the TRM instead of the PCL5 for manualized trauma therapies, such as cognitive processing therapy?
Well, I'd love that, but I haven't heard any talk at this stage. But I think anything that kind of, looks at kind of shifting into this positive space, I would be all over.
Yeah. Someone asked, do you have to be a psychologist or a psychiatrist to administer the TRM?
Absolutely not, no. And
I
I
think
think
that's one of the wonderful things about it. It's just so it's so something that is so intuitive that I think, you know, clients are going to get it immediately, and we're not speaking about pathology. So yeah,
it gives, I guess, because it gives those clinical interventions and not specifically for a psychologist, but a counselor or a mental health worker or even self-driven. These are things that, if people have heard of, there's so much access to resources these days. So, even if someone was to take the recommendations, if they self-administer and they take the recommendations around enhancing positive sense of self and what that looks like, then they could, chuck that into Google, chuck that into GTP and start looking at how they could do that independently as well. So it's not just a clinical, it's not just a pathologizing, it's not just, a restricted space. This is a space where anyone can help themselves and help anyone else.
yeah, fantastic. So, Sharelle, thank you so much for talking with us tonight. It's been an absolute pleasure. The chat was absolutely going off. And thank you, the audience, for coming out tonight and investing time in understanding how we can all improve our practice that little bit so that we can serve our clients a little bit better. If you enjoyed this webinar, we've got another webinar coming up about death anxiety, a transdiagnostic target, and with Dr. Rachel Menzies. That's coming up next month. And if people want individual supervision with Dr. Sharelle Smith, Sharelle, I understand that you provide that at the Lightner Centre, and people can go to that website and get individual clinical supervision with you.
Absolutely, yes.
Excellent. All right, thanks for coming out, everyone, and take care.
Thank
Bye.
you.